Hello guys and welcome back to my channel. This is Dr. A Sajid. It's about 11:30 at night and I was going through the nice guidelines for urinary tract infection. I thought let's just go through it together so that we can have a little bedtime reading session. First up in the nice guidelines, it talks about the definition, and with the definition it divides it off into, let's change the color a little bit. So it divides into lower urinary tract infection, which it also defines as cystitis, so it's infection of the bladder. It then talks about the upper urinary tract infection, which it defines as the infection of the kidneys and the ureter, and it also calls it as pyelonephritis. The third definition is recurrent UTI, and this is where I think the guidelines win because they give you an exact number. It says greater than equal to 3 episodes per year or greater than 2 episodes per 6 months. So 3 in a year or 2 in a month, in 6 months. Then it talks about catheter associated UTI, and again this is also where any guidelines would win because we'd want to know what is the time limit for the catheter to be inserted, and it needs to be in for greater than 48 hours. It lastly talks about bacteremia, which is just the symptoms of, which is just the presence of bacteria irrespective of symptoms. It could be symptomatic or asymptomatic. Once it's given out its definitions, I think these are very, very important because it helps you put down your definitions into your diagnosis and makes you sound far more smart and far more educated with the choice of words that you would use. The most common organism that's causing UTI is the E. coli. We'll just put it forward. There's a big one in the top. That's all right. It talks about risk factors, which I think was pretty interesting if we're sitting in like a general practice kind of clinic. And the risk factors, it divides off into young people or elderly / postmenopausal. Most of these risk factors were given. I mean, they were quite simple, like young people with a history of UTI, young people with a family history of UTI, or having sexual intercourse would be at risk of UTIs. But with the elderlies, it talked about postmenopausal elderly people with a history of UTI. I found this pretty interesting. Anybody with urinary incontinence could be at a risk of UTI. Atrophic vaginitis or catheterized patient or increased post residual void, all of these people are risk factors to UTIs, and I found this pretty interesting in terms of just practicing where we'd want to think of such things. The symptoms itself are pretty simple. They're very straightforward. Nothing that would take us off balance. So the symptoms it describes is dysuria, which is painful maturation, increased frequency, which is polyuria, increased urgency, nocturia, and it talks about change in urine. So it talks about the smell and the color, and I think this last one is something that you'll see a lot more in care homes, where your colleagues, your fellow nursing colleagues and HCAs will tell you that, doctor, the color of the smell in the last few The color and the smell of the urine have been very different from what they've been. If you're working in urgent care or in ED, you'll see this symptom more, which is suprapubic tenderness. And the guidelines itself doesn't miss out the opportunity to pick up something more complicated, the pyelonephritis, which simply presents with three things: fever, rigors slash chills, plus loin pain, and also plus minus nausea now that I think about it. So it touches briefly upon pyelonephritis, and that so far is the definition and the signs and symptoms of UTI. What it goes on to next is possibly the most interesting part, and that is the urine dipstick. The reason behind that is that's the kind of test that's very, very commonly used, and I think understanding where and what happens is very interesting and it's very important for us. So it just takes a bit longer. Let's just break it off. Hold on. Almost done. Right, almost done. Right. So over here now it talks about, when it talks about assessment, it brings in the famous urine dipstick, right? And with the urine dipstick, there are a few scenarios where we'll talk about. There will be a chance where there would be a point where we would not do not use dipstick. And the NICE guidelines talks about two places where is the patient is catheterized, the patient is greater than 65 years of age. And it's because of research that anybody who's greater than 65 years of age, you might find bacteria, but they might not actually be having a urinary tract infection. So it's better to not, it's not good to do a dipstick, but it would be better to just send off the urine and see if the culture grows it. And in terms of catheterization, it becomes complicated as well. So these are the two conditions where we don't do urine dipsticks, or we'd want to avoid urine dipsticks at most cost. Then it talks about nitrites, leukocytes, and RBCs. Now, if we've got nitrites, leukocytes, RBCs positive, that's a UTI. If the leukocytes are positive but the nitrites are negative and the RBCs are negatives, it's still classified as a UTI. And if the nitrites, leukocytes, and RBCs are negative, then that's classified as unlikely UTI. I think that was very, very important, because the place where nitrites are negative but leukocytes are positive, the understanding that it gives off is that it basically the leukocytes predominate in infection, but it might be caused by bacteria that doesn't produce nitrites. That is the reason why it comes back as negative. So those are the four scenarios that one can have with UTIs. To be honest, given how extensive the test it is, it could be way worse than this. After talking about this, the NICE guidelines talks about when you'd want to send off a culture, and from this slide ourselves, anybody who's getting catheterized or is greater than 65 years of age would need to be sent for a urine culture. And anybody who's had like recurrent UTIs or isn't getting better with antibiotic treatment, or is producing signs of hematuria, would want a urine you would want a urine culture instead of a urine dipstick on them. It also talks about the differential diagnosis. The differential diagnosis were, to be honest, I found them very, very broad. So it talked about the first differential diagnosis, which was, I think, pyelonephritis, that none of us would want to miss. But then it went off on to talk about gynecological issues like lichen planus or lichen sclerosis or atrophic vaginitis, which is absolutely true because you tend to see this a lot in GP settings where the patient's urine culture comes back negative, but the symptoms sound very much like UTI. Third would be dermatological conditions like psoriasis and eczema. And then something you'd see a lot more would be STI, and lastly would be drugs. Drugs like cyclophosphamide and codeine tend to mimic symptoms of UTI. So this is UTI that we've read together just before going to sleep on a Sunday. If tomorrow we'll do the rest of the part where we sit down and study the remaining bit of the UTI guidelines together. If you'd like to see more of this content where we try to go through crammed website guidelines together, don't forget to like, subscribe, and comment on the channel. Thank you guys. Bye.